Thanks for listening to the Wild Health Podcast. For the foreseeable future, you're not going to hear our normal intro or outro here. We're going to be releasing episodes very frequently as things are changing. This channel will be used for a very specific purpose. Number one, to communicate with our patients. We're somewhat overwhelmed, and the more we can communicate breaking news and recommendations from us to our patients all at once, the better. So if you're a patient, we're here for you if you need us, but if possible, please tune in here so we can both keep you up to date and conserve our time for the most critical tasks. Feel free to share this with friends and colleagues as well. Number two, we've organized as a group. We have infectious disease specialists, ER doctors, critical care doctors, and in total dozens of MDs, PhDs, and frontline clinicians who are going to be constantly evaluating the news and emerging evidence. We're then going to summarize and translate that for you here every day on the podcast. The speed of change with the circumstances will make us look foolish at times, but we're committed to pouring all of our resources and energy into doing what we can to help and make a difference. You can also follow our updates at wildhealth.com or our Instagram account at wildhealthmd. And if you're a patient, we're here for you. Please tune in here for the updates and let us know how we can help. Good morning, April 21st. Thank you for joining us for a COVID-19 update. Currently, there are 782,000 cases and 41,000 deaths in the United States and approximately 2.5 million cases and 169,000 deaths worldwide. The increase in deaths in the United States is up 5.1% and cases 3.6%. I bring up those two percentages, Mike, because it's a massive difference from just a couple weeks ago when we were talking about 23 and 27% increases. So it's really good to see the increases really start to level off. Data from the Financial Times shows that daily new coronavirus cases in the United States continue to flatten, further indicating that the outbreak in the U.S. has peaked. The death toll in the United States remains the highest in the world, however, and continues to rise. Although this is expected because death rates are a lagging indicator, as we've talked about before. Brazil, India, Turkey, and Russia are battling growing outbreaks. Turkey now has more cases than Iran had at the same stage, while Brazil is seeing a disproportionately higher death rate. The outbreak in Japan also continues to grow, with Japan's total number of cases now surpassing South Korea's. There's several promising signs that were reported in New York today. The single-day death toll in New York fell below 500 for the first time since April 2nd. In his daily briefing yesterday, Governor Cuomo reported that both the daily death toll and the 3-day average of hospitalized patients in New York had fallen for the 6th day in a row. The daily increase in new coronavirus cases was the lowest since March 21st, with approximately 4,700 people diagnosed in the past 24 hours. At the outbreak's peak in early April, just a couple weeks ago, that number was 9,000 new cases a day, so it's half as much. While major outbreaks across the country seem to be leveling off, there are some new hotspots that are emerging. Massachusetts is facing a surge of cases with more than 38,000 cases. It surpassed Michigan to become the third hardest hit state after New York and New Jersey. New workplace-related clusters have been identified in states across the Southeast and Midwest, signifying that the virus can still be propagated through essential workers. The official government response to the coronavirus outbreak continues to consist of a patchwork mix of policies implemented on a state-by-state or even county-by-county level. Many states, including Michigan and New York, continue to warn the White House that they do not have the testing capacity to safely reopen the economy. Meanwhile, other states like Texas and Florida are already lifting social distancing restrictions despite seeing no apparent slowdown in their outbreaks. Findings from a new study from Harvard demonstrate that the United States cannot safely reopen unless it conducts 3 times as many coronavirus tests as it is currently administering. Currently, an average of 146,000 tests a day are being conducted across the United States. The researchers estimate that in order to safely reopen the country by mid-May, between 500,000 and 700,000 tests should be performed a day in order to identify infected patients and safely isolate them. Currently, 20% of tests conducted in the United States have been positive for the virus. The researchers note that expanded testing will bring that number closer to 10%, which is the maximum rate recommended by the WHO. Countries that have drastically flattened the curve, like Germany and South Korea, attribute their success to early and widespread test and trace programs. The rate of positive tests is 7% in Germany and less than 3% in South Korea. So if we're getting 20% positives and Germany is getting 7% positives, this is not a fact of us just having so many more cases. This is more of a fact of they're doing better job of testing and identifying those who really should not have that high of a positive test rate.
Yeah, testing. I feel like we keep talking about the same thing over and over and over again. Speaking of testing, a couple of articles that I wanted to talk about. The first one, I don't think we've talked about this yet on the podcast yet, Matt, but I know you and I talked about it briefly together. That Stanford study where they were looking at the prevalence in Santa Clara County. We didn't talk about that, did we?
No, we didn't. It came out, I think, right after we did the last update. I think we felt like we've talked about it because I know you and I probably talked about it to like 24 people at least, because it was a pretty interesting study. But
It is, yeah. So this one was released on April the 11th, technically, although I don't think it really got on anybody's radar until a few days after that. And it was a study performed by Stanford School of Medicine, and their goal was to measure the seroprevalence of antibodies to COVID-19 in a population in Santa Clara County. And they did their best to make it a population that was representative of the people that live in that county. So there was a total of, I think, 3,300 or so volunteers that ended up getting their blood tested, basically. And they use that lateral flow immunoassay. And depending on what you assume their sensitivity and specificity to be, they found out that somewhere between 2.5% and 4.16% of the population actually had the antibodies to COVID-19, which is around 85 times more than the number of confirmed cases at that time. So this is an interesting study. The most interesting part to me, Matt, is when you really dig into the study and start looking at the sensitivity and specificity of these tests. And we've talked about this multiple times on the podcast. There's a lot of variability in the testing for the antibodies. This one, they came up with a sensitivity of around 80% and a specificity of 99.5%. So interesting study. I mean, nowhere near what we need for herd immunity, but it does suggest that there is a prevalence in the population of asymptomatic carriers that is way greater than I think most of us even expected.
Mike, is this good news or bad news?
I think it's good news. I mean, I think bad news would be that, like everybody who gets sick is symptomatic. And this tells us that the case fatality rate is way lower. I mean, astronomically lower than 3%. If there's that many people out there who don't have positive tests, but have seroconverted.
Yeah. The reason I ask is I think there's clearly good news and there's clearly bad news in this. It's, in my mind, the bad news is that this is spread much more than we thought it has. It also means that there are a lot of asymptomatic people that could be spreading it. So trying to contain the virus, in my mind, just got a lot harder based on this. That's the bad news. So when we do open back up, this is going to spread. I guess the good news, just like you said, the infection fatality rate, so how many people that are infected that actually die, is going to be much lower than the case fatality rate that we're calculating right now. So if it's 50 times more prevalent, then obviously 50 times you're changing the denominator in the equation of people who die compared to people who have COVID-19 or have SARS-CoV-2, we should say. It's COVID-19 is the syndrome. So the amount of people that are infected, a much lower percentage are actually dying. So it's a less serious illness, but it's also much more widespread. So that's the good news and the bad news, I guess, of this study. Either way, it helps us plan better.
Yeah, certainly. And I mean, just to put a little math to it, even if we weren't talking about a 50 times, say the study was exaggerating things. If say that case fatality rate was 5%, and we're talking about a 10 times increase in prevalence, now the case fatality rate is down to 0.5%. So you can see how a 50x or an 85x would dramatically reduce that case fatality rate, which it doesn't mean that there's still not people who are going to die from the disease. That's still obviously going to happen, but the risk does seem to be lower than previously believed if these numbers do in fact become true.
Yeah, if the infection fatality rate is 0.5, it's still 5 times worse than the flu, but it's a lot better than 3 to 5%. And even if it's 50 times more, then your fatality rate actually starts to approach the flu. But I want to make sure people don't equate that with, oh, well, this is just the flu. It's not. It's much more. The R naught is much different. It's a much higher number of people that have it. So it's a complicated math and complicated equation, but there's definitely some good news in this as well. It may not be as serious as we had once thought as far as fatality rates.
Yep. A couple other interesting articles. The Oura Ring is taking is a little bit more interest in multiple academic institutions. So West Virginia University recently launched a study. They're initially looking at monitoring 200 healthcare workers for signs of COVID-19. They're expecting to expand that to 1,000 and then 10,000. This actually started, I think, because apparently the founder of Oura Ring ended up getting COVID-19 and noticed it on his ring. And I know we've talked about this previously on the podcast, but it is interesting to start using some of these wearable devices to monitor for likelihood of infection, especially when you can't find a test anywhere. The last article I want to talk about is from South Korea. This is not actually published data yet. This is coming from the press, so take this with a caveat.
Hey, Mike,
but there have.
Before you talk about that, I would point people, if you're really interested in the Oura data or how to use your Oura Ring, we do have a specific podcast that Mike Stone and Mike Mallon did on that. So just search for that, how to use home monitoring devices. We published it probably a little over a month ago, but we talk about how to actually look at your HRV and your temperature. And we've been using it this way for a long time to figure out when we are going to get the flu or an illness, and can kind of modulate your workouts and other things to try to improve your immunity and not suppress your immunity anymore, and potentially avoid an infection. So we have a whole podcast on that, and we're also talking about that. It'll be part of the town hall, the webinar that we're doing on Wednesday evening, because some of these devices may be helpful as we talk about returning to work and returning to play, and we're monitoring large groups of people.
Last article I want to talk about is coming out of South Korea. So this is not actually literature. This is an article that was in the press, so take it with a large grain of salt. There has been a report that around 160 people in South Korea who were thought to have recovered from COVID-19 infection have tested positive a second time for the virus. Apparently, the South Korean government is conducting a review of the cases. The doctors involved with the review believe that the virus may have reactivated in patients, meaning that it's reemerged after going dormant for some period of time. Research, however, is thus far incomplete and inconclusive. Epidemiologists worry that this finding could cause the outbreaks to linger longer in the population, particularly at a time when countries like South Korea considered loosening the social distancing restrictions that have so far slowed down the spread of the outbreak. There's been a lot of talk about this in the media as well as on social media. And I wanted to just take a minute to talk about it between the two of us, because we don't really know what's going on here. I mean, let's be honest. Can we truly trust these positive real-time PCR tests that were performed on these patients initially when they initially tested positive? Can we trust them the second time that they've tested positive? I mean, we've gone over this time and time again. We don't truly know the test characteristics associated with all of these coronavirus tests, whether it's the immunoassays or whether it's the real-time PCR. So the likelihood in my mind is far greater that there was a testing error than someone is actually getting sick a second time. We certainly don't have any immunoassays on these patients to figure out whether they seroconverted or not. So before everybody freaks out, I just want to remind everyone to take a step back and think about this for a second. Is it the testing that's inaccurate, or is it the virus and the immune system that's inaccurate?
Yeah, and I think the key point that you just made is we just don't know. I mean, like we've talked about before, it's very possible that someone tests positive, they have it. The specificity seems to be really good. You're probably not going to get a false positive, but it is highly likely that you get a bad sample, they test negative, it's still active, it's still there, and then they test positive later. Now, this is a pretty delayed testing positive, so it's kind of less likely than the studies we've talked about before. And there are viruses that behave this way. We know shingles, for example, can be reactivated later. It lays dormant. HIV, you can be infected with it, and then it can cause a syndrome later. This is a coronavirus, so it should behave more like a coronavirus. So we wouldn't think that it would do this. I agree with you that the issue is probably more related to testing than it is a quote-unquote going latent and becoming reactivated. But we got to be honest that this is a novel coronavirus. We don't know exactly what's going on, so we're just going to keep following the data. We do make some guesses, but just be clear, what we're talking about is what is plausible but not necessarily what is probable. So all of these questions, can you get reinfected? What is the actual prevalence? Can you monitor with the Oura Ring? All of these things are going to be really important as we talk about the big question that's on everyone's mind, which is when can we open back up? And not just when, but how can we open back up? So again, we've mentioned it several times, but we're going to spend significant time on this exact question with a panel of experts on Wednesday evening this week, April 22nd at 5:30 Eastern Time. If you want to be a part of that discussion, it's completely free. Sign up at wildhealth.com, and we're going to discuss as a group. We'll answer your questions as best we can in as honest of a fashion as we can, and we're all going to start formulating a plan. We're already formulating a plan for this. We're doing this for multiple organizations when it comes to return to sport and return to work. But the more of us discussing this, we believe the better. So this isn't going to be a proprietary thing. Any protocols or anything that we come up with, we're going to share as broadly as we can. We do think we need as many people involved in the discussion as possible. We have some guests potentially that are going to come from the American Enterprise Institute, potentially some folks that work with the CDC as well. We haven't confirmed exactly, but we're trying to get several good guests, more than just us talking about it. But if it's just us and it's just you, then join us anyway. We'll have a good time, and hopefully we'll all learn something from each other. Tomorrow morning, we'll have another podcast for you. Ryan Smith is going to be talking about peptides for immunity on Wednesday morning, and then Wednesday evening at 5:30 is the webinar. Thanks for listening.
Thanks so much for listening to this COVID-19 update. Please send us your questions or follow along on Instagram and Facebook at WildHealthMD. And just to be clear, this is not medical advice. No patient-physician relationship has been established, and this resource is really for general informational purposes only. And finally, if you want to spread the word, please send this podcast to friends and family and give us a review on iTunes. Thanks again, and stay safe.